Thanks for having me talk today. I'm going to give some updates about the testing that we did at the Baltimore conference last summer. And I'll be talking today about speech, language, and cognitive phenotypes in MED13L, gives the latest project updates and just a brief summary of where we're going to go next with this. So my name is Marissa Mitchel. I'm a speech pathologist at the Geisinger Autism and Developmental Medicine Institute. And both I and Cora Taylor, who's our pediatric psychologist here at ADMI, were lucky enough to go to Baltimore last year and test many families with MED13L. So before I start, I want to thank the Simons Foundation for their support. And of course, thank you very much for all of the families who participated in this work last year. Obviously, this kind of research would not be possible without your support and without your participation. I do want to mention that the data that I'm going to be talking about today is preliminary. So we've done some preliminary analyses. We're hoping to gather some more data, but nothing here has been peer reviewed or published in any platform at this point. So you should, everything we talk about, you should keep that in mind. And then any information I present today shouldn't be interpreted as medical advice. So as always, you should always discuss with your care team before making any decision making as far as medical needs and concerns. So I'm going to give some background first. Speech impairment, language delay, and motor delay, as many of you know, are some of the most commonly reported features associated with MED13L. But the previous studies that I've read have really provided very little detail about specific areas of difficulty. So speech impairment, language delay are really large, broad categories that encompass many things. And so one of our main objectives is to better figure out exactly what those areas are of strengths and weaknesses. There are two ongoing studies that I'm a part of right now that aren't yet published, but they're in the works. And actually, as part of both of these studies, I've been looking at children who have diagnosed motor speech disorders and then trying to figure out if there's a genetic etiology that can explain those motor speech disorders. And in both of these cohorts, we found children who had MED13L variants. So this is the first thing that interested me and spurred me to kind of want to find out more, that maybe motor speech disorders is a major part of the phenotype associated with MED13L variants. So our objective for this study is to describe in detail the speech, language, motor, and cognitive features that are associated with MED13L variants in an effort to inform treatment recommendations in the future. So first, motor speech disorders might not be a very familiar term to many of you, so I'm going to go over what those are. So when we think about speech, for most of us, it's not something we really think about, but it's really a complex enterprise. It involves a lot of different steps, and these happen so quickly with most people that you don't even think about it. So the first thing is this cognitive linguistic stage where you have to decide what you're going to communicate and start to formulate that message. The second stage is called transcoding, and that's where you have to plan and program the sequence of motor movements that are required to produce sounds. After that is motor execution. So this is actually carrying out those motor plans. That's using the motor plan, the lips, tongue, jaw, soft palate, respiratory system. Those are called the articulators to actually carry out or execute the motor plan. And then lastly is the sensory feedback. So sensory feedback is auditory. So we hear what we've said and we think, how did that sound? Did that sound the way that we intended? And also proprioception. So how did it feel? Did it feel the way that I thought it would when I articulated that word? So when we talk about motor speech disorders, we're really talking about two stages. We're talking about the transcoding stage, so planning and programming, and then the execution stage, which is actually carrying out that motor plan. So truly, speech sound disorders is a broad diagnosis, and it's a very, very common problem of early childhood. So approximately 5% of all young kids present with some type of speech sound disorder. But under the umbrella of speech sound disorders, motor speech disorders are relatively rare. And you can see here, motor speech disorders are things that impact execution, which typically lead to dysarthria, or motor planning, which leads to apraxia. So we can define speech sound disorders as being caused by deficits in either motor planning and programming, which leads to childhood apraxia of speech, or motor execution, which typically leads to dysarthria. There's a third group that we sometimes talk about of speech motor delay, or sometimes we call it motor speech disorder not otherwise specified. And these are children who might demonstrate some features of apraxia or dysarthria, but they don't fit neatly into one category or another. And many children actually present with features of both. And so it is certainly possible to have a diagnosis, for instance, of both apraxia and dysarthria. Apraxia and dysarthria can vary in severity. So it can range from mild to severe. Kids with mild motor speech disorders, you might be able to understand much of what they say, but you can tell that things just sound a little bit off. Children with severe motor speech disorders might be minimally verbal and really struggle to communicate effectively through speech. In general, apraxia and dysarthria have a low population prevalence. So even though speech sound disorders are relatively common in childhood, both apraxia and dysarthria are quite rare. And so if we look at the general population of children ages 4 to 8, the best estimates we have are that it occurs in only approximately 1 in 1,000 children. We do know that motor speech disorders are more common in certain populations. So children, for instance, who have complex neurodevelopmental disorders, such as intellectual disability, global delays, or autism, they have a higher likelihood of having either apraxia or dysarthria. And then we already have knowledge that certain genetic disorders are associated with high rates of apraxia or dysarthria. And some of the disorders that perhaps you've heard of before would be 16p11.2 deletion syndrome, 22q11.2 deletion, and then another family group that came to our conference last year is SETBP1 related disorders. So we do know that there are certain genetic disorders that are associated with a much higher likelihood of presenting with some kind of motor speech problem. So at the conference last year, we had 16 probands who participated in at least some aspects of our speech and cognitive testing at the Searchlight Conference. 7 were males, 9 were female. The mean age was 10 years, but we had a nice range between 4 and 17. And then 12 patients, and there was some overlap with the ones who participated in the speech and cognitive testing. So a subset of those patients also consented for an MRI records release, and subsequently, we've been able to obtain those MRI records for a portion of the children. The testing protocol that we used last year, so in the area of speech sound production, there were a few tests that I used. 2 direct tests that were given to most children were the Goldman-Fristow test of articulation, which does provide a standard score. And it's not specific to apraxia or dysarthria or motor speech problems. It's really just looking at a child's sound inventory and the specific types of sounds that they're having trouble with. I also gave a test called the dynamic evaluation of motor speech skill. And this doesn't provide a standard score, but it does provide some evidence that a child might have difficulty with motor planning and programming. So things like disordered speech praxis, so difficulty with sequencing sounds, difficulty with things like prosody. These are all things that I can get some more information with the DEMS. And then lastly, for each child, I completed something called the Profile of Childhood Apraxia of Speech and Dysarthria, or the ProCAD. And this is really a diagnostic tool that helps a provider figure out if something is apraxia or dysarthria or possibly features of both, because differential diagnosis between motor speech problems is sometimes tricky. Secondly, we looked at language skills, and there were 2 specific tests that I gave, the expressive vocabulary test and the Peabody picture vocabulary test. The expressive vocabulary test required a child to label pictures. So they'd be shown a picture and I just would say, what is this? And then the Peabody picture vocabulary test is looking at receptive vocabulary. So when given a set of 4 pictures, the child has to find the one that matches the word that I'm talking about. So it's really a measure of comprehension of words. For cognition, my colleague, Dr. Taylor, gave a variety of different tests depending on the child's age, skills, and abilities, included the differential ability scale, or the DOS, the Mullen, or the KBIT2, depending on what the child was able to accomplish and how old they were. And then many children were able to complete a fine motor measure called the Bury-Buchtenka Developmental Test of Visual Motor Integration, which is a mouthful, so we usually call that the Bury-VMI. I'll go over the preliminary results for speech first. What was quite interesting was the high percentage of children who met criteria for at least one motor speech disorder. So out of the 16 probands that I tested, 13 of those probands presented with at least word level speech. There were 3 children who were minimally verbal, and so I wasn't able to make a confident differential diagnosis to say whether or not there were motor planning deficits. There may have been, but those children are not going to be included when I talk about the testing for speech. Out of those 13 verbal children, all of them actually met criteria for at least one motor speech disorder, and that would include apraxia, dysarthria, or both. And then four of those children also had diagnoses of something called a phonological disorder. Now, this isn't a motor speech disorder. This is a cognitive linguistic deficit that impacts a child's knowledge of phonological rules. This is a more common speech sound disorder, but I did look for evidence of that as well. And so this visual just kind of shows what diagnoses the children had. So with the yellow circle, you can see that these were children who had apraxia. The blue circle are children who had dysarthria, and there was some overlap. So 5 children actually met criteria for both, 7 met criteria for only apraxia, and then 1 child had no evidence of apraxia, but they did have a diagnosis of dysarthria. I also looked at oral motor speech skills, and this was something that was based predominantly on clinical observation as well as parent reports. So I didn't do a lot of specific oral motor testing, but it was, as children started coming in, I noticed that this was something that seemed quite prevalent with this population. So out of the 16 children I saw, 50% reported some type of oral motor dysfunction. So this is oral motor dysfunction, not including speech. 4 children, even some older children, presented with drooling, and parents indicated that this has been an ongoing concern for them. 4 children had a history of significant difficulty feeding in infancy. 2 children actually required a G-tube in infancy because they weren't able to swallow. And then 2 children also presented with what's called an open mouth posture, which can sometimes be indicative of some low facial tone, so low muscle tone, where the mouth tends to be open and sometimes the tongue protrudes just at rest. I also asked about use of augmentative and alternative communication strategies. So these are tools and strategies that are oftentimes used to supplement or replace spoken speech. Typically, children who use AAC fall into one of 2 categories, either children who are verbal but are very, very hard to understand, or children who just have very limited verbal speech in general. So out of the 16 children who we were able to test, 6, which is 38%, currently use some form of AAC. 5 use speech generating devices. So for most kids, these were tablet-based devices, sometimes an iPad with a communication app. And then 1 child used sign language. 1 additional child we did test is nonverbal, but so far hasn't been successful using one AAC strategy or another. Okay, I'm going to talk about standardized language and cognitive and fine motor testing. And before I talk about that, parents sometimes already have this knowledge and some parents don't. So I always just go over this when I talk about testing, standardized testing. So in standardized testing, children fall in what's called a normal distribution. And so essentially what we do is we compare a child's raw score, so the number of items that they get correct, with a large group of children who are the same exact age. And this allows us to calculate a standard score. We usually say the exact average standard score is 100, but we usually say the average range is between 85 and 115. So that's 1 standard deviation below to above, 85 to 115. So that would be considered an average performance. Below 85, we would typically consider below average, and then above 115, we would say that's above average. And so these rules apply for the following tests. So if you'll recall, I gave 2 separate language tests, and these were looking at single word, either receptive or expressive vocabulary. So the PPVT is looking at receptive, so comprehension, and then the expressive vocabulary test, the EVT, is looking at expression. Occasionally with children, you'll see a big gap between these. What's more typical sometimes is kids will understand more words than they're able to produce. So you might see a higher score in receptive compared to expressive language. But what we found for the children who participated in our testing with MED13L variants is that their performance was quite similar. So if you look at the mean standard score in both receptive and expressive, actually the score was slightly higher in the expressive subtest, although that difference is not statistically significant. So 56 to 61 is where the means were across those 2 measures. So I would say there was similar performance, similar impairment in both receptive and expressive skills. For cognitive testing, again, we didn't see statistically significant performance between subtests. However, we did see a trend where many children performed better on the nonverbal IQ section, which is like problem solving, visual motor, rather than verbal. So verbal tended to be an area of significant vulnerability for a lot of children. The overall IQ mean was 55, which would fall in typically the mild to moderate intellectual disability range. And that's what we found for the majority of children, with the trend in better performance in nonverbal IQ compared to verbal. One area that we found to be a particular area of vulnerability was in fine motor skills. And so my colleague, Dr. Taylor, gave the Beery VMI to take a look at visual motor processing and fine motor skills. And out of the 16 children who we attempted to complete the assessment with, actually only a little over half were able to complete it. 9 out of 16 were able to complete it. So some of the prerequisites for completion would be the ability to reach out, for instance, and hold a pencil, to be able to make some marks and scribble on paper. And so a significant minority of children were not able to do those particular tasks because their fine motor skills were really quite impaired. And so the score that we found, the average score, which is about 58, this should be considered kind of an upper estimate of ability, at least for this group of children who we were able to test, simply because there were quite a few children whose fine motor is so impaired, we weren't able to give this test. So it does appear that fine motor skills is one area that is quite significantly impaired in the MED13L population. So I want to give a brief summary of our results. So all of those things that we found, what are the take-home messages? First, all verbal children, so the 13 children who were verbal, all of them met a clinical diagnostic criteria for at least one motor speech disorder, which would be either apraxia, dysarthria, or 5 children who actually met criteria for a diagnosis of both. At least half demonstrated generalized oral motor difficulties. So if you recall, many children presented with drooling and open mouth posture or significant feeding problems in infancy. A sizable minority benefited from AAC strategies. So many children used tablet-based devices to help supplement their speech, typically because their speech was quite challenging to understand to other people. Receptive and expressive language was impaired to a similar extent, and the degree of impairment ranged from mild to severe. So there was a pretty wide range of what we saw with children. There wasn't a significant gap that we found between comprehension and production. We found that those things were impaired to a similar extent. Most children presented with an intellectual disability, and this was generally in the mild to moderate range. And there was a trend that there was better performance on nonverbal subtests compared to verbal subtests. And then lastly, we found that one area of particular difficulty was fine motor. So many children were not able to complete a measure of fine motor that we attempted, and those who did tended to score in significantly below the average range. So next steps that we have right now, the first thing that we'd like to do is include additional phenotypic data that's already been collected through the Simons Foundation. So many of your family members may already have completed some of these measures. So that would include things like adaptive measures, such as the Vineland, the MHI, and then the seizure questionnaire, and see if maybe there are some different aspects of the phenotype that are related. So for instance, is it possible that children with seizures present with worse speech or fine motor skills? And that's something that we'd like to take a look at and pursue. Secondly, we'd like to analyze the MRI data that some families have been able to provide to see if there are certain brain differences that are present with MED13L variants, but also whether or not those brain differences might underlie some of the differences in motor speech and fine motor that we're seeing. And then lastly, this is something that we're in the process of doing right now, and that's additional recruitment with direct speech and cognitive testing of programs who have MED13L variants through our clinic here. So we do follow some children here who have MED13L variants. We've already collected some information, but we're still in the process of recruiting some more families to include in what we hope to eventually be a manuscript that we submit for publication, where we talk about, case series looking specifically at things like language, motor speech disorders, fine motor, and cognition. Thank you again so much to all the families out there who have contributed to this research. Partnering with you is the only way that we're able to make new discoveries. So I want to thank you very, very much. And then if you have any questions at all about the material that we've presented, please feel free to reach out to Simons Searchlight directly, and they can put you in touch with us if they can't answer your question. And we're happy to try to answer anything. So the email address is here, coordinator@simonssearchlight.org. And thank you very much. I hope to see you at some future conferences.